All right, so um, metabolic syndrome, that is another common adverse effect of the older atypicals, those first generation. Metabolic syndrome is definitely an adverse effect associated with the typicals, but it's more common in the atypicals. All right. So this is one way that we can keep up with the differences between the atypicals and the typicals. And we'll talk more about the typicals in a second, the atypicals in a second. All right. But what is metabolic syndrome? Weight gain, right? Usually around the central area of the body, like we call that central obesity or abdominal obesity. All right. So we get the patient having experiencing the apple shape as opposed to the pear shape, where the abdomen or the central part of the body gains more weight. That's metabolic. Um, Also, we might see insulin resistance, which is an early sign or a sign that this patient is not properly regulating or their insulin levels on their own. All right, they might actually be heading into diabetes, right? Which you can sometimes see starting as insulin resistance. All right, and then dyslipidemia. There's another one of those big multi-compound words. Dys meaning not regulated, lipid meaning our lipids or our body's fats, right? Emia, meaning in the blood. All right. So a person who's dyslipidemic might have an elevated cholesterol or an elevated triglycerides. Okay. Dyslipidemia. Usually they're talking about the triglycerides and cholesterol. All right, and what are the risks here? Cardiovascular disease and diabetes. All right, this is my area of research, metabolic syndrome. So I could talk about this all day, but we're going to move on. Metabolic syndrome, it can be an acute scenario for a person on this antipsychotics, right? But it can become a chronic issue like diabetes or cardiovascular disease if we don't monitor that patient, watch their labs over time, and teach them lifestyle changes that will help them kind of keep their weight in control, and lower their risk for what this medication is already increasing their risk for, and that's metabolic syndrome. All right, so keeping the BMI low, keeping the blood sugar under control, having a lipid panel to keep an eye on that cholesterol, and making the lifestyle changes will help monitor or will help mitigate that patient's loss. Okay, another adverse effect of antipsychotics, sedation. There it is. The antipsychotics put you to sleep, right? They do. And the newer generation drugs have Z in the name because, as I mentioned before, anytime those drugs contain the word Z in it, it's usually because there's a sedating effect. All right, so there are nuisance side effects and then there are emergencies. So I want you to know the difference between those nuisance side effects like drowsiness, dry mouth, constipation. Remember, those are anticholinergic effects. So dry mouth, constipation, urinary retention. Because again, with anticholinergic drugs, we're trying to bring down the heart rate, keep down the blood pressure. This may cause drying out of the system. All right. So urinary retention, constipation, dry mouth. All right. And here's that one. Um, QT prolongation, you see that in the atypicals. If you do and have been exposed to that, what like a typical EKG strip and how it looks, then you'll know that there are different intervals, right? So you have the P wave, and then you have the Q, all the way RS, right? That you see, right? That forms an interval. And then T is another wave. But if there's a prolongation in the Q to T interval, then that could be an indication that this person is experiencing some negative side effects from those medications. And you'll see that definitely in the typical haloperidol or Haldol, but we also see it in ziprasidone. There's one of those Z drugs, and that is an atypical. All right, so those are other side effects. Some of the contraindications. right? Contraindications, we don't give these to people who are in a coma. We don't give these meds to people who are having CNS depression. All right. And remember, we talked about last week what CNS depression would look like, right? It is kind of an obtunded state or a state of kind of like almost somnolence. All right. Hypersensitivity, we would not give that to a patient who would be hypersensitive to the drug, meaning that they are allergic, essentially. All right. We'd use it with caution in people who already have cardiovascular disease. Why? Because we don't want to worsen their already present cardiovascular disease, diabetes, or even seizure disorders, because we are fooling around in those centers that also manage the seizures. There is a black box warning on these drugs, all right, because there's an increased chance of death or mortality in folks who have dementia. All right, so contraindications, coma, depression, CNS depression, okay, cardiovascular disease, and dementia. All right, so those would be important. How do we teach our patients? How do we teach our patients taking the typicals? All right, we want them to stay on their meds consistently. All right. Stopping suddenly would be bad. Okay. There will, I think we talked about sudden stopping of medications when we were talking about depression, right? Same thing here. All right. Again, because we are tinkering around in centers of the brain that control other centers of the brain, when we stop taking something for one effect or another, we actually may cause an overproduction or overreaction or biofeedback loop that causes a cascade of actions we do not want or responses we don't want. Okay, so no sudden stops. We want to train the brain and tell the brain that we're getting ready to taper off by stopping at a regulated paced rate. Okay. All right. So we want to teach them to report their fevers. We want to teach them to report a sore throat, abnormal movements, major weight gain. All right. For the orthostatic hypotension that comes with the atypicals, right? Because remember, we're using anticholinergic medications, so they would take that blood pressure down, right? So we don't want them to go hypotensive to the point that they experience orthostatic hypotension. Um, some people don't have high blood pressure who are taking antipsychotics. So if they take a medication that lowers the cholinergic effects of schizophrenia itself, then they might experience unintentional hypotension. All right, so we keep an eye on that and teach them how to rise slowly so that they don't experience the orthostatics. All right. And of course, because alcohol is a CNS depressant, we're going to limit the use of alcohol. All right. Limit or ask them, just avoid it. Avoid it. All right. Most of the time. Um, yeah, that's why I just want to point that out. Alcoholics or people who struggle with alcohol or substance abuse issues will have a difficult time if they develop schizophrenia, right? Because the medications to treat them are in direct contraindication with their other comorbidity of alcoholism. So we really want to look out for those folks. All right, so now we're going to shift over to the second generation agents or the atypical antipsychotics. All right, they have been developed to improve how they work or efficacy and those horrible side effects tolerability. All right. We want them to be able to tolerate their meds, so they will take them. All right. So these have been developed over time to kind of treat the positive symptoms and the negative symptoms, not just reducing positive, but also affecting some of those negative symptoms like the anhedonia, avolition. All right. And then we're also wanting to lower those dangerous adverse effects risks like EPS, NMD. I'm sorry, NMS and TD. All right. So we also, because they're at that risk for gaining weight unintentionally, developing these metabolic risks, Uh, uh, you know what I'm going to say? I don't want to read this wrong. There is a higher metabolic risk with the antipsychotics. They were the atypicals. They were not developed to reduce metabolic risk. That is an unfortunate crisscross negative effect, that metabolic risk, because sometimes when you treat one problem, you create another. So I can't really say a lot of times, because we're working in the brain, how we can be so precise. I can't say how science or pharmacology or the pharmacists or whoever do the development of these drugs, I can't say how easy it is to stop one problem, without full knowledge of how the brain works, to stop one problem without creating another. All right. So remember, the higher metabolic risk goes along with the atypicals. All right. Even higher than the atypicals. All right, but these second generation drugs evolved over time. The prototypes are risperidone, olanzapine, and clozapine. You see all those Z's in there? All right. Risperidone has an analog called ziprasidone. All right, so the dones are similar in behavior. Risperidone, ziprasidone. Olanzapine, clozapine are prototypes that are alike as well. Okay. So the mechanism of action around the atypicals, they're a little bit more nuanced. Okay. So they block both the D2 dopamine receptors and the 5-HT2A serotonin receptors. All right. And remember, before I mentioned that serotonin was implicated along with glutamate, they're also implicated in schizophrenia. So this is a dual action drug, or these tend to be dual action drugs that kind of give better symptom relief while being effective in treating both the positive and the negative symptoms. So it's believed that the additional 5-HT2A antagonism molecules, kind of not molecules, but the neurotransmitters, they modulate dopamine in a way. So they kind of, and when you say modulate, it doesn't mean like they just kick them out. It's really more about finding an even ground, right? And these are dual action, usually trying to do both the decreasing of the negative symptoms and, I'm sorry, decreasing the positive symptoms and increasing the negative, well, not increasing the negative symptoms, but improving the negative symptoms, all right, or addressing the negative symptoms that the typicals usually don't treat. All right, so what are they going to do? Hopefully, reduce the hallucinations and delusions, that's the positive symptoms, and then improve the mood, motivation, and affect. Those are the negative symptoms, that we mentioned before, improve those. All right, there are fewer incidents of extrapyramidal symptomology seen in these atypicals than what you see in the typicals. Clozapine. All right. So clozapine, we don't want to use unless we are dealing with a person who is treatment resistant. All right. Because of this big old fancy $5 word, agranulocytosis. Agranulocytosis. Let's break it down. A meaning away from, removing, a lack of. Granulocytes are, well, granulo means like they look like little grains, like sugar, right? Grains. Cytes refer to cells, right? And cytosis refers to the destruction of cells. All right, so agranulocytosis is the destruction of white blood cells. We don't want that. We need our defense cells, right, in case we have an infection. So you have to monitor the patient's labs. All right. And I need you to focus in on CBC. If you don't know already, the CBC, or complete blood count, that is a lab test that's going to capture how many white blood cells are present in our patient. All right. So if we do the CBC and we see that the white blood cells are there, in adequate numbers, we don't worry about it. Okay. We've done our job. We have scanned our labs to see that our patient is not at risk. But NCLEX loves this type of question. They will, when I say NCLEX too, guys, I hope you don't think, oh my gosh, she's always talking about the NCLEX. That's so far away. You're juniors. It's coming, right? It's coming sooner than later. And I'm an NCLEX coach, so I am inclined towards like what I know about the NCLEX, sharing that with you. But our questions come from ATI, which is highly correlated to the NCLEX style question. All right. So when I'm saying this, I mean our tests as well. All right. They love to ask you about agranulocytosis as it relates to the atypical drug clozapine. Okay. Um, that's our big key word, our big key special consideration. All right. So how are you going to how are you going to work with your patient? You're going to educate them about what it looks like to have infection, right? Because if the white blood cells are reduced in this patient, and then they start to experience what people who have low white blood cell counts experience, then they might develop infections, all right? So we want to educate them about the signs of infections so that we can be cued to have a CBC ordered for them. Or we are not going to do the ordering, but we communicate things to the team so that they would understand that an order would be needed. Okay. All right. So other risks of clozapine include seizures, myocarditis, and weight gain. What is myocarditis? That's another one of our five-letter words or $5 words. Myo meaning heart, right? Or muscle. Myo means muscle. Carditis means heart. So the heart muscle itis, meaning inflammation of. So inflammation of the heart muscle, myocarditis. That's a risk with clozapine. All right. So know those special considerations for sure. All right. Clozapine and agranulocytosis. Remember, this is a hematological risk here. Hematological, meaning having to do with the blood count, the blood um, components. All right. So we're going to need that CBC, right? So you really want to make that connection, clozapine and hematology, clozapine and white blood cells. All right. So the unique risk agranulocytosis. So we monitor those WBCs weekly and then a couple times a month. And then maybe even monthly once we stabilize. All right. So the real risk is once they start taking this drug and we just keep an eye on them. We hold the med if we see our patient back and they have WBCs of 3,000 or less. Okay. That said, the symptoms are going to include fever, sore throat, malaise, and we report that. Sore throat, why? Because they might be developing an infection. Malaise, that term, generally speaking, is referring to just a general feeling of uh, like poor health. So malaise often like an unexplainable blah, terrible feeling. Um, yeah, it's hard to describe, but it could be it could look like fatigue, it kind of presents in different ways. But that said, you'll tell them what malaise is. That's a term that we might use with the team, but not a term we would use with the patients. All right, so clozapine is not a first-line drug. We do not give that. That's only for the patients who are resistant to treatment. All right, so but the first line drugs in many settings today for schizophrenia would be these two. All right, olanzapine. Now, olanzapine does come with that high metabolic risk, right? Those people do develop weight gain and diabetes if, more so than the folks taking clozapine. Risperidone, fewer metabolic risks, but it does like increase one's prolactin levels. Okay. And there's an increased risk in high doses of EPS. All right. So whereas EPS is typically associated with your typicals, these two atypicals, which happen to be the first line, do see EPS risk. All right, or extrapyramidal syndromes, extrapyramidal, extrapyramidal never mind, EPS symptoms. Both are widely used, olanzapine and risperidone, all right, for both the positive and negative symptoms. All right. So let us move on to our next one here. Let me just do a quick check, make sure we're okay with our screen here, and I'll do a time check as well. Okay, I could be moving a little bit faster. All right, so the atypicals, we'll just redouble on that concept, all right? Because of those metabolic symptoms, you you can see patients who don't want to take their meds, who wants to gain weight and develop insulin resistance or have their lipid levels be out of whack, right? Who wants that? So our nursing interventions will include like measuring their baseline BMI so that we can know if things change, keeping an eye on those blood sugar levels, even if they have no evidence of being diabetic or having elevated blood glucose levels. And then we want to also monitor those lipid levels, all right, asking for a lipid panel, a lipid panel. All right, with that said, we can support our patients through those lifestyle changes or lifestyle education. Okay, and here's just here's a depiction or a table that just helps us to break down those symptoms. I'm hoping this is helpful for you. But if it's not, you can develop your own tables or work with your cards. Whatever you do, you must get these concepts down. They will be tested. Okay. Now, I think we mentioned already what we're going to do in terms of our nursing interventions for atypicals. All right, we're going to reinforce long-term adherence, and in order to do that, we're going to have to be supportive of their need to be educated around lifestyle changes, right? So we're going to educate them around the sedative side effects. We're going to educate them around the possibility for low blood pressure when they're standing. All right, so there's a lot of nursing intervention and to consider with our patients taking psych medications for psychosis or antipsychotics. All right, so on your drug card, you might have for clozapine the following. All right, so check that out, see if it matches or works well with your drug cards, and feel free to build this into your drug card if you don't have it already. All right, I hope that I've put enough emphasis on there for you to know what you might see on the exam. Same thing here for risperidone. All right. Hopefully you guys are learning. If you learn a trade name, you must know the generic name. So learn the generic names and you don't have to worry about, maybe when you get into the environment, you're gonna the working environment, you're gonna want to know the trade names because your patients know the trade names. But for the sake of what we're learning in this course and moving forward, I really want you to focus on the uh, generic drug names. All right. Olanzapine, there's a drug card example for that. You should contrast olanzapine with risperidone so that you can see the differences. Okay. Here's an example of how we might contrast the typicals versus the atypicals. So when I say contrast, I mean really kind of break down the main differences in ways that you can distinguish them one from another. All right. And hopefully in seeing this summary table here, you can anchor your testable distinctions. Okay. So D2 blockade for the typical first generations, D2 plus 5H2 5-HT2A blockade for the atypicals, for example. Okay. All right. All right. Why am I mentioning the benzos and the SSRIs here? I remember putting this here, but this is not in the right place. It just should be at the exam review. So if I don't mention it again, let's do just a foreshadowing that this will be important teaching um, uh, for you to know when it comes to our SSRIs and our benzos, nursing teaching that you might do for your patients. Now, could a patient who was schizophrenic be on a benzo? Probably not. That's why I know this is out of place because, um, again, why not? I want you to think about it. I'll give you a second to think about it before I give you a response. You can pause if you want to. All right, I'm going to say it. Sedative effects, right? The sedation, the potential. If you have to tell people on benzos to be careful of operating heavy machinery like vehicles or heavy machinery at work because of the sedating effects, then imagine what would happen if you added to the patient's typical or atypical schizophrenic treatment regimen a benzo. All right. Yeah. And you don't want to mix alcohol with those. So if I don't come back to that, know that that slide, although there and out of place, would be important for our exam review. All right, concept map. So, can you make a concept map that helps you link this disease, schizophrenia, to the drug, antipsychotics, both typical and atypical, and also the nursing care? All right, I hope so. That's what the last hour was about. All right, so your assignment will be, and again, this is a non-graded assignment, is to prepare by building the cards, using the learning templates, using your ATI resources, using the flashcards. I think it's really great to study using different methods, guys. So if you use and your own study guide materials that you write and make up on your own, that's going to give you the secret special sauce